So we said that fixed law of diffusion is dependent on the diffusion coefficient, which is dependent on the solubility divided by the square root of the molecular weight of the gas and the pressure gradient, and all these factors are divided by the tension. So the lung diffusion is measured by using carbon monoxide because it have a high affinity for hemoglobin, which is approximately 200 times that of oxygen. So does not rapidly build up in plasma. Under normal conditions, it has low blood concentration. So normally it's zero, and pulmonary concentration is zero. So we are controlling the amount of carbon monoxide as we want. Is diluted and absorbed. Thus, the inspired carbon monoxide, when is divided by carbon monoxide, is greater than the inspired helium when divided by the expired helium. So we are measuring the carbon monoxide by two means, either by infrared scanning or by helium. So we are measuring the carbon monoxide here by comparing it uh, to the helium dilution. The ratio of carbon monoxide uptake to helium dilution must be more than 1 because we know that carbon monoxide is both diluted and absorbed, and the helium is not diluted nor absorbed. So the ratio of the inspired carbon monoxide is more than the expired carbon, the amount of the inspired carbon monoxide is more than the expired carbon monoxide, and the amount of the inspired helium is the same as the expired helium. So the ratio of inspired carbon monoxide divided by the expired carbon monoxide to the inspired helium divided by the expired helium is more than 1. So this is one of the means. By comparing it to helium, we can measure the diffusion of carbon monoxide. It is assumed that carbon monoxide is absorbed exponentially because exponentially because the amount of carbon, the intrinsic amount of carbon monoxide in the alveoli is zero and in the capillary is zero. So the diffusion is dependent totally on the amount that we administer to the patient. So the absorption is exponential during the period of breath holding because the partial pressure of carbon monoxide is zero in the pulmonary blood and the pressure gradient in the alveolar pressure of the gas. The alveolar pressure of the gas is the gradient for the gas because it's zero in the capillary. If we have a carbon monoxide of 5 millimeter mercury in the alveoli, that means we have a pressure gradient of 5 because in the capillary it's zero. So it's 5 subtracted from 0 and the result is 5. Therefore, the lung diffusion of carbon monoxide is equal to the ventilation multiplied by carbon monoxide ratio multiplied by 1 divided by the breath holding time multiplied by 1 divided by dry barometric pressure. So the total lung diffusion is dependent on the total lung ventilation and alveolar ventilation. We measure the alveolar ventilation, which is the tidal volume multiplied by the respiratory rate And the alveolar ventilation is multiplied by the ratio of the inspired carbon monoxide divided by the expired carbon monoxide, and these factors are multiplied by 1 divided by the time of breath holding. The patient inspire, hold breath to allow the carbon monoxide to diffuse, and we multiply these factors by the time that patient hold breath, 5 seconds, 4 seconds, and we multiply then 1 divided by dry barometric pressure, and the units are carbon monoxide uptake per unit time per pressure unit difference from alveolar gas to blood. So we have a pressure unit here, we have a time, we have a pressure. So the unit is or are carbon monoxide uptake per unit time per pressure from alveoli to the blood. Time per pressure, time per pressure, unit time per pressure.
Time per pressure. طيب.
Yes. The diffusion, the lung diffusion of carbon monoxide when divided by the alveolar ventilation is calculated by dividing the carbon monoxide diffusion by the alveolar ventilation, which is measured at the body temperature and pressure saturated with water vapor. So we do these tests at normal body temperature, normal water vapor saturation, which is 47%. So here is a diagram. Here's the time. Here is the time. Here is the volume. The patient have normal functional residual capacity, started to breathe normally, inspired and expired, and he expired, and then we started timing from here after we give the patient the specific air that containing the carbon monoxide and helium to inspire it. It contains 0.3% carbon monoxide, 10% helium, and the other oxygen. So the patient inspired deeply until he reaches the total lung capacity and he hold breath. Then the patient starts to expire. Here is the stop time. It's only 8 seconds. And the patient starts to expire and we collect the air. After the patient expire approximately 1.5 liter, then we stop collecting. The amount of the extraction of carbon monoxide is dependent on. So I gave the patient a specific amount of air. I gave the patient a specific amount of air, and this amount of air containing a specific amount of carbon monoxide and helium and oxygen. I told the patient to hold for 8 seconds. Then I told the patient to expire, and I collected the air. After that, I compared the inspired carbon monoxide divided by the expired carbon monoxide, and divide all this by the same ratio for the helium, inspired helium divided by the expired helium. Then I obtained the ratio, and I calculated the minute ventilation for the patient, or the alveolar ventilation, I mean, which is the tidal volume times the respiratory rate, and subtracted from the alveolar dead space. Then I use this alveolar ventilation by multiplying it by the carbon monoxide ratio, and then I multiply these factors by the inverse dry barometric pressure and the inverse holding time, which is 8 seconds. And the net result is the diffusion of carbon monoxide, which is normally must be 20 to 30 milli per minute millimeter mercury, and this when multiplied by 1.23 gives us the diffusion of the lung diffusion of oxygen. So this measurement is dependent on, as we said, the diffusion capacity of the alveolar membrane, the thickness of the alveolar capillary barrier, and the pulmonary capillary blood volume, and the hemoglobin that is coming to contact with the inhaled gas. So always the diffusion of the carbon monoxide depends mainly on the alveolar function, except when the airways are abnormal and deep breath is not evenly distributed to all parts of the lung, when the concentration of the hemoglobin in red cells is not normal, and this is coming from here. We said it's dependent on the volume, and it's dependent on the diffusion, and it's dependent on the hemoglobin. So it's always a factor of the diffusion and the membrane function, except there is abnormal hemoglobin and abnormal ventilation perfusion. So carbon monoxide diffusion will only be a function and a factor of alveolar membrane function when airways are normal and hemoglobin concentration is normal. So when there is no emphysema, non-emphysema, or non-anemia. There are two ways of reporting diffusing capacities. Either we can say the lung diffusion of carbon monoxide is the uptake of carbon monoxide per unit of alveolar carbon monoxide in the whole lung, or saying that the diffusion of the carbon monoxide divided by the alveolar ventilation is our value. We can report it as an absolute unit or as a ratio with the alveolar ventilation. So we can either measure the diffusion of the carbon monoxide as a function of the rate of uptake of carbon monoxide per unit of alveolar pressure, partial pressure of carbon monoxide in the whole lung, or we can use it as a function of the alveolar ventilation. So this index is known as diffusion or transfer coefficient. Diffusion or transfer coefficient, and it's equal to the diffusion of the lung diffusion of the carbon monoxide divided by the alveolar ventilation. Both of them are used differently clinically. In practice, they are useful in separate situations. As we said, the calculation of the lung diffusion of carbon monoxide without dividing it by the alveolar ventilation, I mean calculating the ratio by dividing the inspired carbon monoxide over the expired carbon monoxide multiplied by the minute ventilation multiplied by the inverse dry barometric pressure and the inverse hold time of the breath. This diffusion of the carbon monoxide when it's considered alone, it assumes that regional variations of ventilation are all averaged out. There is no variations between any sides of the lungs. There is no shunts. There is no pulmonary embolism. There is no congenital heart disorders. You see? And in patients with respiratory failure, sometimes severe ventilation perfusion mismatch can result in marked abnormalities of CO2 and O2 exchange when the diffusion of carbon monoxide is normal, because the exchange of CO2 and O2 is dependent on the whole lung, but the diffusion of carbon monoxide is dependent only on the function of the alveolar membrane. So sometimes in the setting of abnormalities in the perfusion, in the ventilation perfusion mismatch, in the setting of ventilation perfusion mismatch, sometimes we can have a normal diffusion of the carbon monoxide, but still it cannot have a good indication for the real situation of the oxygen and CO2 exchange. Inversely, in the setting of low carbon monoxide diffusion, sometimes is compatible with a normal resting arterial PO2. You can have a patient with a normal resting arterial PO2, but still when you do testing for the carbon monoxide diffusion, you find that the carbon monoxide diffusion is reduced, and oxygen exchange in exercise is invariably abnormal when carbon monoxide diffusion is low, which means that in these patients that have normal resting oxygen and abnormal resting carbon monoxide diffusion, you expect those patients to desaturate when they exercise, i.e., they have subclinical fibrosis, non-fibrosis, or diffusion limited pathological condition. So the interpretation of the lung diffusion of carbon monoxide and the lung diffusion of carbon monoxide divided by the alveolar ventilation are useful in the situations of normal forced expiratory volume 1, forced vital capacity, and vital capacity, and hemoglobin. As we said, the diffusion of carbon monoxide will be capturing the function of the alveolar membrane when the hemoglobin and the airways are normal. So in the setting of the absence of obstructive pulmonary disorders that does not affect the alveolar membrane and the absence of abnormal hemoglobin, the low lung diffusion of carbon monoxide strongly suggests that there is a disorder that involves the alveoli. While in the setting of obstructive disorder, an obvious obstructive disorder, the patient is having a wheeze and have low forced expiratory volume 1 and forced vital capacity the patient with low lung carbon monoxide diffusion is always considered to be having emphysema, chronic obstructive pulmonary disorder. In contrast, the carbon monoxide diffusion may be high in patients with asthma, which is also one of the types of obstructive disorders of the lung. The restrictive pleural and chest wall disorders, a high lung carbon monoxide diffusion divided by the alveolar ventilation, so the transfer coefficient is high in the setting of restrictive disorders. Which type of restrictive disorders? We are talking here about the extrinsic type of restrictive disorders, not the interstitial. When they are widespread radiological lung shadows, opacities, such as in sarcoidosis or some occupational lung disease, scoliosis, co-worker lung diseases. Lung diffusion of carbon monoxide reflects lung impairment and disability, but it's not considered directly with the extent of the abnormalities on the plain chest X-ray. So when we have an abnormal lung diffusion of carbon monoxide in the setting of abnormal X-ray, we always consider impairment and disability of the alveolar membrane. And when we have an obstructive pattern, the patient with low diffusion is considered to have emphysema. Patient with high diffusion is considered to have asthma. Polycythemia, pulmonary plethora, heart failure, left to right shunt, congenital heart disease like VSD, pulmonary hemorrhage increases the lung diffusion of carbon monoxide because of the increase in the hemoglobin in the alveoli. Factors that decrease, conditions that decrease lung diffusion of carbon monoxides are emphysema, lung resection, pulmonary